Hello and welcome. I'm Fernando, a GP in the UK. Today, we will go through a new guideline on diagnosing, monitoring and managing chronic asthma, focusing on what is relevant in primary care only. Given how extensive the guidance is, in this episode, we'll just focus on treating asthma in patients aged 12 and over. If you haven't already, I recommend checking out the previous episode on initial assessment and diagnosis. In the next two episodes, we will finish the guideline by covering treating asthma in children aged 5 to 11 and those under 5, and then asthma monitoring, general treatment principles, and management in special groups. So stay tuned for those. Right, let's jump into it. And let's remember that the new guideline is a joint initiative by NICE, the British Thoracic Society, or BTS, and the Scottish Intercollegiate Guidelines Network, or SIGN. It replaces previous guidance, and you'll find a link to the new guideline in the episode description. Before we start, we need to be aware that from a treatment perspective, there are three groups of patients: those aged 12 and over, those aged 5 to 11, and those aged under 5. NICE has produced summaries of pharmacological management in the various age groups, and a link to them can be found in the episode description. And today, we're going to focus on the pharmacological management in people aged 12 and over. And we're going to look at two areas: the management of newly diagnosed asthma, and how to transfer existing asthma patients being managed on the basis of previous guidelines to the new guideline. Let's start with newly diagnosed asthma. As the initial management, we will offer a low-dose inhaled corticosteroid, formoterol combination inhaler, to be taken as needed for symptom relief. This is what is called as needed air therapy. So what is air therapy? It stands for anti-inflammatory reliever therapy, where formoterol is used as a reliever in an inhaler that also contains an anti-inflammatory corticosteroid. While many of us may be familiar with the MART regimen, that is maintenance and reliever therapy, air therapy is different. It involves using a formoterol corticosteroid inhaler only in response to symptoms, without regular maintenance dosing. Currently, only specific budesonide formoterol inhalers are licensed for this, with a low-dose budesonide formoterol combination being recommended as on-demand air therapy. The use of any other inhaled corticosteroid formoterol inhaler would therefore be off license. If the patient presents highly symptomatic, for example, regular nocturnal waking, or with a severe exacerbation, we will start treatment with low-dose MART, maintenance and reliever therapy, instead, in addition to treating the acute symptoms as necessary, for example, giving a course of oral corticosteroids if needed. We will then consider stepping down to as-needed air therapy using a low-dose inhaled corticosteroid formoterol inhaler at a later stage if the asthma is controlled. By the way, for guidance on what doses of inhaled corticosteroids are considered low, moderate and high, NICE, SIGN and BTS have produced tables showing the various inhaled corticosteroids and their different doses that you can refer to. You can find a link to these tables in the episode description. And what comes after the initial on-demand air therapy? Well, if symptoms are not controlled on a low-dose inhaled corticosteroid formoterol combination inhaler used as on-demand air therapy, we will offer low-dose MART. And let's remember that MART, or maintenance and reliever therapy, is when a single inhaler containing an inhaled corticosteroid and formoterol is used for daily maintenance therapy and the relief of symptoms as needed. The terms low-dose MART and moderate-dose MART refer to the dosage of the maintenance component of MART. People using MART do not normally need a SABA. And obviously, if symptoms are not controlled on low-dose MART, we will offer moderate-dose MART instead. For those whose asthma is not controlled on moderate-dose MART, despite good adherence, we will check the fractional exhaled nitric oxide or FeNO level, if available, and the blood eosinophil count. If either of these is raised, we will refer to secondary care. If neither FeNO or eosinophil count is raised, we will consider a trial of either a leukotriene receptor antagonist or a long-acting muscarinic receptor antagonist, or LAMA, used in addition to moderate dose MART. We will give them for a trial period of 8 to 12 weeks, and at the end of the trial, if asthma is controlled, we will continue the treatment. If control has improved, but is still inadequate, we will continue the treatment and start a trial of the other medicine, either leukotriene receptor antagonist or LAMA, depending on what was given first. However, if control has not improved, we will stop the first drug that we chose, either the leukotriene receptor antagonist or LAMA, and then start the trial of the second medicine. When prescribing leukotriene receptor antagonists, we should be aware of the MHRA safety advice on the risk of neuropsychiatric reactions in people taking montelukast, including children and adolescents. Reported neuropsychiatric reactions include sleep disorders, hallucinations, anxiety and depression, as well as changes in behavior and mood. We should advise patients to be alert to these risks and report any concerns. If asthma is not controlled despite treatment with moderate dose MART and trials of a leukotriene receptor antagonist and a LAMA, we will refer to a specialist. Let's now look at how to transfer existing asthma patients from the previous guideline to the new one. So what do we do with them? Well, those currently using only a short-acting beta-2 agonist, or SABA, should be changed to a low-dose as-needed air therapy using an inhaled corticosteroid formoterol combination inhaler. For those whose asthma is not controlled on regular low-dose inhaled corticosteroid plus PRN SABA, both with and without supplementary therapy, that is, a leukotriene receptor antagonist, and also those on regular low-dose inhaled corticosteroid LABA combination inhaler plus PRN SABA, also with and without supplementary therapy, that is a leukotriene receptor antagonist, we will consider changing them to a low-dose MART. For those whose asthma is not controlled on regular moderate dose inhaled corticosteroid plus SABA on demand, both with and without supplementary therapy, that is, with or without leukotriene receptor antagonists, or LAMA, or both, and those on regular moderate dose inhaled corticosteroid LABA combination inhaler plus PRN SABA, both with and without supplementary therapy, that is, with or without leukotriene receptor antagonist, or LAMA, or both, we will consider changing treatment to a moderate dose MART. When changing from low or moderate dose inhaled corticosteroid or inhaled corticosteroid LABA combination inhaler plus supplementary therapy to MART, we will consider whether to stop or continue the supplementary therapy, that is, a leukotriene receptor antagonist or LAMA, based on the degree of benefit achieved when first introduced. Those whose asthma is not controlled on treatment containing a high dose of inhaled corticosteroid should be referred. On the other hand, if asthma symptoms are completely controlled, we may want to consider decreasing maintenance therapy. In these cases, at annual review, we will discuss the risks and benefits of decreasing their maintenance therapy, and we will update the asthma action plan and arrange self-monitoring and follow-up. When decreasing maintenance therapy, we will stop or reduce the dose of medicines in an order that takes into account the clinical effectiveness when they were first introduced, as well as their side effects and the patient's preference. We will allow at least 8 to 12 weeks before considering a further treatment reduction. And if we're considering step-down treatment for those on a low-dose maintenance inhaled corticosteroid plus a SABA as needed, or a low-dose MART, we will step down to on-demand air therapy with a low-dose inhaled corticosteroid formoterol combination inhaler. So that is it, a review of the treatment of asthma in patients aged 12 and over. We have come to the end of this episode. Remember that this is not medical advice, but only my summary and my interpretation of the guidelines. You must always use your clinical judgment. Thank you for watching and goodbye.